Very good evening to all of you. I welcome you all for this second academic session of CPSIG. And today I have a very interesting talk on movement disorders and cerebral palsy by Dr. Biju Amit. I request our President, Dr. Shefali Gulati ma'am, to introduce the expert and the speaker for today. Over to you, ma'am.
Thank you. Thank you, Mahesh. Welcome for this SIG series. So we have our dear friend, Dr. Biju Hamid, who needs no introduction. And I think Biju is synonymous with Ikna and Ghosh. So but a very dear friend working with focus on neurorehabilitation among many others, and now right now establishing neuroscience services in the UAE in addition to working in Ghosh. Thank you so much, Dr. Biju, for always supporting us. And we have two experts, and we have one big stalwart from pediatric neurology, Dr. Rajesh Urani, who's been very kind to have joined as an expert. And he's an amazing professional and is an amazing human being. And you've heard many presentations on movement disorders from Sir. And we'll be having Dr. Jackie Ganguly, who is a consultant neurologist and movement disorder specialist in Institute of Neurosciences, Calcutta, who will be joining with us. So we would be having a flavor both of pediatric and adult neurology analysis, so we can have an overview about the same. And I would hand over now to Dr. Prashant, who will be moderating the session. So, I mean, that Q&A will start after that. So, Prashant, you want to welcome Dr. Biju, and Dr. Biju can then start sharing the slides.
Yes. Welcome each and everyone, and thank you, Biju Amit sir, for joining us and sparing your time. And thank you, Rajesh sir and Ganguly sir. So I think we have already crossed 8 o'clock, so we'll start it. Sir, I request Biju sir to start it. With chair's permission, ma'am. Shall we go ahead?
Sure.
Yes.
Thanks, Dr. Shefali and Dr. Prashant, Rajesh, and nice to meet you all again. I quite enjoy this series, and congratulations to the president. So today we will have, I'm sure it's a topic which we are all familiar with, but I think it's quite important to make ourselves aware of this condition, or cerebral palsy is synonymous with pediatric neurology, and cerebral palsy is probably the best prototype for a movement disorder in children, perhaps in adults as well. So if time permits, what we will do is we will briefly go through with the different types of cerebral palsy, but with a specific emphasis on the dyskinetic type. We will discuss a bit detail about the dyskinetic cerebral palsy. We will also spend some time on the concept of spastic dystonic CP. And then we will talk briefly on the overall principles of management of dyskinetic CP. So it's always nice to remind ourselves of the definition of cerebral palsy, which we all know is a problem with movement and posture, which causes limitation in activity. And it is attributed to, as we know, a non-progressive disturbance which occurred in the developing brain. And we all know that it is associated with a whole host of comorbidities across all domains, including sensation, perception, cognition, communication, behavior, not to mention epilepsy and other secondary musculoskeletal problems. And it is the most common cause. And despite all the advances that has happened in the last several decades, the incidence has sort of remained the same. I mean, some authors quote 1 to 2, some others quote 2 to 3, but particularly in resource-rich countries, the incidence has remained the same despite all advances. And on the basis of the predominant motor disorder, it has it's clinically categorized into spastic, dyskinetic, ataxic CP, which is quite intuitive classification. And the dyskinetic CP is characterized by abnormal postures or movements associated with major movement disorder patterns. The two major patterns, or the three major patterns that we know, one is the dystonia, chorea, and athetosis. Dystonia predominates with abnormal postures, involuntary twisting, and repetitive movements due to sustained or intermittent muscle contractions. While choreoathetosis, chorea, we know, are rapid, involuntary, jerky, fragmented movements, while the athetosis is the more writhing, contorting movements. So the classification of the predominant motor types has been addressed in various international cerebral palsy registers. In Europe, the classification of the predominant motor type is completed using the surveillance of cerebral palsy in Europe, the hierarchical classification tree, which is shown here. And this classification relies on your clinical judgment. And the primary purpose of this is to monitor the trends in rates of cerebral palsy across Europe. And as we know, it is classified into the spastic, ataxic, and the dyskinetic type, which includes the dystonic, choreo, and athetoid cerebral palsy. And those children with mixed motor subtypes are classified according to the predominant clinical feature. And one disadvantage of this hierarchical classification, or perhaps a limitation of this classification, is that the mixed tone cannot be easily accounted for. The classification only accounts for the predominant motor type. And this is the case with other registries as well. For example, the Australian CP register. It can also be used by a limb approach as well. Now, it is widely recognized that many children with cerebral palsy have both spastic and dyskinetic features. But the general consensus is to continue to classify them by the dominant motor type, but then in addition, list the secondary motor types. And so which means when you say a mixed CP, it should be accompanied by an elaboration of the component motor disorders. Now, as we will see in later in the course of this talk, it's not actually very clear-cut, although the term spasticity has been probably used and abused in clinical settings, both also in the lay population. The topographical classifications are limited because they do not provide any information about the function. They do not provide any information about the activity or the participation or how severely each child is affected. Hence the reason why we have functional classification systems. So, first developed by Palisano and group in the mid-90s. So these provide insight into the functioning level of the child and how they mobilize, how they use their hands, how they communicate and eat and drink. So they do not provide information on the quality of the child's movement, but if you combine this with the topographical and the motor type classification, then we have a common language to converse, to describe our patients. So it's very important to remember the 5 levels of GMFCS as depicted on this cartoon here, with increasing severity where GMFCS 5, where the child has got no means of independent mobility, while 3 and 4, they can sometimes, they need assisted devices for walking, and rely on wheeled mobility at home and in the community. While GMFCS 1 is where the children can walk both indoors and outdoors, but perhaps sometimes have difficulties on uneven terrains, but generally speaking, they are quite functional. So sorry. The dyskinetic CP, there is a problem with existing registries, because if you look at the various registries, the population-based data across the various international registries, they hugely vary in terms of what is the incidence of dyskinetic CP. But generally speaking, we know it is around 10%. But we also know that from the very small number of population-based studies that that's been done with dyskinetic CP, they have found that the majority of these children are more severely impaired than those with bilateral spastic cerebral palsy. When you look at the GMFCS, most of them falling into the GMFCS 4s and 5s. And it was also found that increasing motor impairment were accompanied by learning disabilities, vision, hearing impairment, epilepsy, etc. So the dyskinetic CPs, you have the involuntary, uncontrolled, recurring, occasionally stereotyped movements, and the primitive reflex patterns also predominate. And the muscle tone in clinical notes, we would often describe them as having a variable tone. And sometimes we tend to use this term dyskinetic cerebral palsy when the dystonia and the choreoathetoid movements are difficult to delineate. So the abnormal postures and the primitive reflexes is often present, as you can see here with the primitive asymmetric tonic neck reflex, or the lack of coordination when in an upright position and trying to grasp the objects, or the large uncontrolled involuntary movements during activity. So these are all hallmarks of dyskinetic CP. So if you look at it in a very simple way, then we know that these can be mild, moderate, severe patterns based on the involvement of the deep gray matter, particularly the basal ganglia and the thalamus. So if you look at the top three, well, here you can see a mild pattern of basal ganglia and thalamus lesions, with the cortex not really being involved, and the outcome would be a dyskinetic CP. While if the injury is slightly moderate, with more central and subcortical lesions, then you would expect a dyskinetic CP with spastic traits, or sometimes you could say like a spastic CP with a dyskinetic trait, depending on how involved the motor cortex is. And then you could have a severe pattern of basal ganglia and thalamus lesions with central cortical and subcortical lesions, and also with the hippocampal lesions. Then you would expect a severely involved child with severe bilateral spastic cerebral palsy. But this is a very, very basic view of how you might think in terms of the basal ganglia and the cortex involvement when you try to differentiate between spastic CP and dyskinetic CP in your head. Now, acetosis, on the other hand, sometimes when it is evident, you notice this slow, continuous, involuntary writhing movement that prevents the child from maintaining a stable posture. The movements appear smooth and random. And usually it involves distal extremities more as well. And it appears in combination with dystonia and chorea. So this is a very classical video which shows the involuntary writhing movements, the overflow of movements in the shoulders and the neck while he tries to perform the task which is asked to do. Dystonia, on the other hand, is the involuntary alteration in muscle activation patterns during voluntary movement, or when you are trying to, when you are at rest, when you are trying to maintain your posture. And there are sustained intermittent muscle contractions, abnormal, often repetitive movements, postures, or both. And as Alvin is classified, it's typically patterned, twisting, or tremulous. And of course, if it can be worsened by voluntary action and associated with overflow muscle activation. Now, at this point, it is quite important to sort of, in our mind, differentiate between the concept of spasticity and the dystonia, because spasticity, we know, is linked to an increase in the velocity dependent stretch responses of a muscle. So that's what is manifested as a catch when you try to move the muscle quickly enough. And then the assumption is that this catch is caused by the hyperactive stretch reflexes. So if you look at the definitions of spasticity, they will all include a hyperactive stretch reflex as the central component of the definition of spasticity. But we know from studies that has happened in the last 2 to 3 decades that the hyperactive stretch reflexes do not cause functional problems, and they do not show any clear relation to the clinical presentation of the child. In spasticity, the reason why the functional capacity is reduced in spasticity is because of the reduced range of movements and the lack of extensibility of the muscle and the connective tissue. And then often at night when they have spasms, those are painful muscle contractions which interferes with sleep, and those are caused by the hyperactivity of the spinal networks, which are different from the stretch reflex circuitry. But what we know very little is about these involuntary movements and the unwanted muscle activity, which are often seen in children who have had a central lesion. And that is the what you call the spastic dystonia. So there is this overactivity which causes the unwanted muscle activity when the patient attempts to maintain a posture or remain at rest. This is the spastic dystonic picture. So in addition to this involuntary activity, involuntary movements while at rest, you can also sometimes see the involuntary activation of the antagonistic muscles to the muscles which the child is actually trying to use. And the also activation of the muscles completely different to the muscles which the child is attempting to activate. So there is spastic co-contraction, and there is also extra-segmental co-contraction, as you can see with this little girl who went on to then have a deep brain stimulation with good results for her dystonia accompanying her spasticity. So when you try to treat these children, the treatment of the clinical manifestations should be directed by the underlying mechanisms. And you have to really differentiate between the spasticity, which is different, and the sustained stretch and effort unrelated involuntary muscle activity, which is present at rest in the absence of a phasic stretch. So which is why in your clinical setting, it's very important to differentiate that dynamic tone, which you elicit by seeing whether there is a catch when you stretch the muscle quickly enough, as opposed to these movements which are mostly seen and not felt, while spasticity, as you know, is more felt than seen. Then you could have this mixed picture, as you can see here again, the spasticity and the dystonia is quite evident. And sometimes there might not be much to see on the MRI scan other than a small volume thalami, and general reduction of the white matter. The dystonia definition, we all know the most accepted definition is one by Albanese, which describes it as a typically patterned and twisting movement. So the spastic dystonia is not something new, because Denny Brown had observed this long time ago, when with experiments in monkeys, were monkeys with lesions to the motor cortex. And even when the sensory input to the spinal cord was cut off, still these monkeys displayed sustained muscle activity. So the involuntary muscle activity basically persisted even when the afferent the sensory inputs into the spinal cord were cut. So which then made him think that there must be a central mechanism to these involuntary movements. And hence the concept of spastic dystonia is not new. And there is a clinical relevance to this concept as well. The reason is there are several centers across the world where the spasticity is managed with irreversible interventions, like, for example, selective dosal rhizotomy, which again essentially abolishing the sensory input to a good percentage. So it assumes relevance from that point of view, where that you have to appreciate the underlying dystonia, which would then make the candidate unsuitable for procedures like selective dosal rhizotomy. And sometimes it is not very evident. As you can see in this boy with hemiplegia, he's asked to walk back and forth initially, and then he's now asked to walk while counting backwards, and you can see the very dramatic posturing of his feet. So this is spastic dystonia, and sometimes it is quite conspicuous in the upper limb, where it contributes to that hemiparetic posture. As you can see with the child adopting a posture with plantar flexion, inversion at the ankle, toe flexion, and extension at the knee, and flexion at the elbow, which was not there originally. But when the dystonia became more prominent, when he is asked to walk and was asked to count backwards. So again, it is very important to differentiate these scenarios where the spastic dystonia. And just to brush up about the pathophysiology of dystonia. Now, we know that there are two basal ganglia pathways that exist, and we could view the basal ganglia as an interactive system which harbors these reciprocal connections, and it influences the motor behavior by the projections to the thalamus, which in turn will influence the cortex, the supplementary motor cortex on the same side. So we have the indirect pathway, which are the GABAergic, indicated by the black lines, the GABAergic neurons that project to the globus pallidus. And the inhibitory neurons from the globus pallidus externa will now then synapse into the subthalamic nucleus, which will then provide an excitatory input to the globus pallidus interna and the substantia nigra, and then will project them onto the thalamus and inhibiting the ventral thalamus. So the green arrows indicate glutamate. So from the substantia, from the subthalamic nucleus, it's most likely excitatory, mediated by glutamate, and then onto the GPI, which then inhibits the thalamus. And these final output structures of the basal ganglia will inhibit the thalamus, and this indirect pathway harbors the dopamine D2 receptors, which are inhibited by dopamine. In contrast, the direct pathway here, it's monosynaptic, directly connecting to the globus pallidus interna and the substantia nigra pars articulata, inhibiting this nuclei, again mediated by GABA, and they express the D1 receptor. So the net result of this system is the two outputs, the indirect and direct, which are differentially modulated by dopamine. And it's like putting a brake on the thalamus and releasing a brake on the thalamus. So the imbalance between these two will then cause the overactivity or the underactivity, as you can see, either in, like, for example, in choreoathetosis or example in Parkinson's. Now, the people have looked at the reasons for why the spastic dystonia exists, but I don't think we really know why this happens. And there's been several mechanisms which has been proposed. Like, if you have a lesion in the central nervous system, then all these things probably happen. There will be altered mechanical properties. There will be sustained involuntary muscle activation. There could be increased proprioceptive spinal reflex activity, increased cutaneous and nociceptive spinal reflex activity. All these things could probably happen because the motor cortex controls the muscles indirectly through its connections to the brainstem nuclei as well. So alongside the corticospinal tracts, you also have the vestibulospinal, the reticulospinal, the rubrospinal pathways mediated via the brainstem nuclei. So what might be happening is, after a corticospinal tract lesion, the motor cortex may reorganize to optimize the surviving output. That means it will try to increase the brainstem nuclei excitability and activity. So that might mean that while the corticospinal tract is impaired, the other tracts, which is mediated by the brainstem nuclei, might still be acting. And for example, those patients with corticospinal tract lesions and who have involuntary activities like the dystonic activities, they still show reduced motor evoked potentials. The reason for that is the motor evoked potentials measure only excitability of the corticospinal tract, and it won't examine the brainstem, the other tracts mediated via the brainstem nuclei. So that might be one reason why this is happening. But the point is, these involuntary movements at rest do happen, and these are cortically mediated, and it's very important to identify them. So this is again a summary of the proposed mechanisms. Well, you could have plastic changes at the spinal level. You could have changes in the intrinsic properties of the motor neurons in the spinal cord. You could have reorganization of the motor cortex, and of course, lesions in the basal ganglia. Now, people have tried to look at whether we can have a little more anatomical correlation with the type of dyskinetic cerebral palsy and the involvement of the basal ganglia. Now, Boomer and colleagues from Boston, so they are quite involved with the cerebral palsy research network, and they tried to look at this with a systematic review involving 22 studies and total of 304 subjects. And they also found that the lentiform nuclei were preferentially involved in dyskinetic CP, and more so with the putamen than the globus pallidus. So you could have a putamen predominant damage, or you could have a pan-lenticular damage involving both the putamen and the globus pallidus. Again, this assumes significance in terms of when you select your patients for deep brain stimulation. So the explanation for the direct and indirect pathways causing these sometimes decreased movements and sometimes overactive movements is still remains an sort of an explanation for the reason why dyskinetic CP. But we know that children who have kernicterus, children who have dyskinetic CP from kernicterus do not behave the same way like children who have dyskinetic CP from hypoxic ischemic injury. There are also other theories which have been proposed, like, for example, there is this oscillatory synchrony between the basal gangliae nuclei, which are impaired in Parkinson's, for example. Perhaps that might be a reason for why the explanation for the pathophysiology behind dyskinetic CP. Because as we all know, sometimes in very florid dyskinetic CPs, sometimes the MRI can still be normal. And Hari Jugani and colleagues had looked at the FDG PET scans in children with dyskinetic CP, and they didn't find any impaired glucose uptake in the basal ganglia. So there is some pathophysiology which is behind this, but unfortunately, even as of now, as of today, we don't really understand the pathophysiology behind dyskinetic CP, and also particularly how these problems evolve. Like, we know that our adult colleagues tend to see more chorioathetoid adults than pediatricians, who tend to see more dyskinetic or the dystonic children. So how the dyskinesia seem to sort of improve while the chorioathetosis seems to get worse. So perhaps our adult colleagues in this session might be able to highlight on that. Now, when it comes to pharmacotherapy, we have moved a lot, and we now know quite a lot about how each of these agents work. Like, for example, the cholinergic interneurons, which constitute around 1 to 3% of all striatal cells, serve as the intrinsic source of acetylcholine to the medium spiny neurons in the striatum. And these cholinergic neurons provide the main source of acetylcholine. And these medium spiny neurons, they are tonically active neurons, and they can fire autonomously without synaptic activity. So the rationale for anticholinergic drugs is exactly that. And while we know GABA here is an inhibitory neurotransmitter, and in addition to the medium spiny neurons, the GABA is present very widely in the neurons subserving the basal ganglia circuitry. Again, the role of GABA in dystonia is unclear. And baclofen is a GABA B receptor agonist at presynaptic terminals of the excitatory glutamatergic neurons, and also at the postsynaptic sites of the inhibitory interneurons of the spinal cord. Benzodiazepines, on the other hand, will increase the frequency of chloride opening, and after binding to GABA A receptors, will then facilitate the inhibition. Dopaminergic neurons, a dopaminergic system, we know the levodopa and two dopamine depleting agents such as tetrabenazine or postsynaptic blockers like neuroleptics. Now, tetrabenazine is probably a good choice when it comes to dopamine depleting agents, because it inhibits the monoamine transporter 2, reducing the transport of dopamine into the presynaptic vesicles, and tardive dyskinesia is not a problem with tetrabenazine. So these are the various drugs, but the important thing is when you try to choose the ideal drug, the therapeutic goal should be carefully determined with the family and the child if possible. You have to take into account the child's development, the ability to walk, pain, and the functional disabilities, and the expected functional benefits. For example, speech, swallow, gross motor control, fine motor control, etc. What we are trying to achieve by using any of these medications. So Darcy Fellings and group from from Holland Blueview had published two excellent systematic reviews. The first one in 2017 and was then followed by an update to the systematic review, looking at the evidence on the pharmacological and neurosurgical interventions on individuals with CP and dystonia. So this was published in DefMed a couple of years ago. And the outcome of the review was the evidence evaluating the use of pharmacology and neurosurgical options in CP and dystonia was limited to between low and very low certainty. There were no studies which met the inclusion criteria for benzodiazepines, for gabapentin, oral baclofen, or medical cannabis. There was some evidence, albeit very low certainty, for Botox, for DBS, for ITD, and in fact for clonidine as well. So that's again the same summary. So that's again the same summary of that systematic review, which, as you can see, there were no studies for oral baclofen, no studies for benzodiazepine, no studies for gabapentin. And then the intrathecal baclofen may improve dystonia. Deep brain stimulation, again, very low evidence. But the reason for this is probably the studies which have been done in the last 10 years have not really addressed the functional outcomes. So anticholinergic drugs, as we mentioned, are widely used in dyskinetic CP. Again, you have to be conscious of these adverse effects. The beneficial response is more specific to upper extremity function, it seems, and also the expressive language, particularly when there is dyskinesia of the jaw. And also, as you know, it will help with the drooling. And again, it is age dependent, as the younger children are more likely to respond to treatment. And as our adult colleagues would say, they tend to be, the side effects tend to be more worse in the adult group. But in children, as long as you start low and increase slowly, it is quite well tolerated. Clonidine, again, there is no evidence, but we all know that we all use clonidine very widely, an alpha-2 adrenergic receptor agonist, and judiciously optimizing titrating the dose, you can achieve good results. Gabapentin as well, another very commonly used drug, particularly in the UK, where it is used to very high doses, sometimes up to 60 to 90 milligrams per kilo per day. Exact mechanism of action is still not very clear. The tetrabenazine is useful, and there are some studies which have shown some usefulness with tetrabenazine, particularly when you try with relatively low doses. But again, the side effects of drowsiness, the worsening of the drooling, restlessness, anxiety, and Parkinson's symptoms, although my experience is Parkinson's symptoms being very, very rare, and sometimes postural hypotension, etc. But it has been shown to be efficient in Huntington's chorea. So sometimes, colleagues sometimes use this where the chorea is also predominant in CP. But you have to be careful, particularly in your patient group, who most of them have an axial low tone, which it can worsen the axial low tone. Levodopa, as we know, all our children with the dystonia is predominant. We always tend to use levodopa. Again, it has to be aware about the usual side effects, etc. There's no evidence of any use, but people tend to use. Botox, there is one randomized controlled crossover trial and 4 non-randomized studies. Again, with focal dystonia, sometimes it can be helpful to prevent the co-contraction of the agonist and the antagonist muscles. But other than that, there is no real indication. But for example, like our boy who was having the passive posturing, his main functional goal was to try and improve his tolerance of his orthosis. And by injecting the tibialis posterior, that was quite successful. So when it comes to, with a particular goal in mind, when it tries to use focally target a muscle, then perhaps Botox has a role. Baclofen, again, it's mainly used, as we know, is for spasticity, but intrathecal baclofen is used in, there's a small evidence for its use in dyskinetic CP. And again, there are the level of evidence is very, very low. Sometimes it may help with the pain and spasms. Sometimes by decreasing the amount of baclofen that you are giving via the intrathecal route would then help with the alleviate the side effects associated with the dose-related side effects, and thereby perhaps improve the quality. And deep brain stimulation, as we know, there is again some evidence with secondary dystonias, but again, the reason why there isn't much evidence is because loads of studies have not been done when it comes to deep brain stimulation for children with secondary dystonia or the spastic dystonic CP, because most of the time, by the time these children are referred for deep brain stimulation, they often have fixed contractures, and in terms of the even when the dystonia improves, in terms of functional improvement, sometimes the outcome is very limited. Perhaps that will change when these children are identified quite early and appropriately referred to neurosurgical colleagues. So the pharmacological, in summary, the Botox may improve goal achievement, pain and comfort for targeting. Intrathecal baclofen may improve dystonia, pain and comfort, but little to no effect on motor function. DBS may result in dystonia, and by achieving that, perhaps it might affect quality of life, but again, very little evidence is there. With trihexyphenidyl, with clonidine, there's a risk of adverse effects are very high. When it comes to benzodiazepines, gabapentin, medical cannabis, etc., there is really no evidence out there. And other interventions like hypotherapy, hydrotherapy, etc. Hypotherapy could work on improving trunk stability and symmetry, and thereby enable the child to overcome the dyskinetic movements. Hydrotherapy, by working on the motor control and relaxation. Assistive technologies for communication, orthosis, etc., would all help to a little extent. Now, it's very important to remember about the International Classification of Functioning Disability and Health, the ICF classification, because this gives you a framework for understanding functioning and disability from a biopsychosocial perspective, and provides that common language and classification of the functioning and disability. And has the four components: the body function and structure, activity and participation, the personal factors, and the environmental factors. And it's very important. And as you can see, the four aspects coming together in this cartoon. It is not a linear model, it's a many-dimensional model. The activities are limited, and hence the participation is restricted, but those are the barriers that we need to break. So when you are looking at an intervention to manage, particularly like in the context of this talk, dyskinetic CP, it is very important that we have to keep the outcomes within the context of the international classification of functioning disability and health. Because this is an elegant paper from Monobalu and team who have published widely on dyskinetic CP. from Leuven, Belgium. They had looked at the functional outcomes in children and in people with dyskinetic CP, and they have shown that individuals with dyskinetic CP exhibited very severe limitations in gross motor function, in manual ability, speech production, but better abilities in eating, drinking, and communication. Again, the dystonia showing significant correlation with the different functional scales across the age groups. It is very important when you try to manage these children to keep in mind their functional abilities. The idea is not to try and stop the dystonia or the dyskinesia, but to improve the function overall. Which is why it's very important in day-to-day practice to always have an focus on the outcome, and particularly outcomes that are meaningful for the patient and their caregivers. In our clinical practice, we use the Canadian Occupational Performance Measure, which is a 10-point scale. It's just 2 questions. The one question is like how, on a scale of 1 to 10, if the child has got frequent trips and falls, then you ask how is he now compared to before the intervention on a scale of 1 to 10. And then the second question is how satisfied you are on a scale of 1 to 10 on his performance. Those 2 simple questions will give you the Canadian Occupational Performance Measure. Similarly, some clinical colleagues like to use the goal attainment scale. Some use the 10-point vision analog scale, but whatever it is, the important point is you have to use a goal which you are familiar with and comfortable with, and the focus should be on the ICF domains. The reduction in the dystonia does not necessarily translate to enhanced function or participation, or does not translate to caregiver burden or quality of life. It's very, very important. So it should be, any intervention should be judged using meaningful outcome measures that reflect the goals and expectations of the individuals. So there are several, the body function and structure can be assessed. For example, the physical assessment using your range of motion, using your goniometer. Pain can be assessed, cognition, anxiety, etc. There are no, when it comes to dystonia and chorioathetosis, it's very difficult on what scales you would use, particularly what scales would be handy in the clinic setting. But you can certainly ask about pain, you can certainly ask about sleep, you can certainly ask about cognition, anxiety, you can get a rough idea. And then for the activity and participation, you can certainly use your gross motor function classification. You can goal setting using the GAS or the Canadian Occupational Performance Measure. Quality of life, etc., might not be very helpful in a day-to-day clinic setting, but if you can find an easy to use assessment tool, then it would be very good. So in this context, it's very useful to remind ourselves about the hypertonia assessment tool, which is a standardized tool that accurately identifies the presence of spasticity, dystonia, and rigidity in children or in people with cerebral palsy. And this was particularly developed to address the need for clinically differentiating between the hypertonias, particularly spasticity, dystonia, and rigidity. It does not identify the presence or absence of chorioathetosis, and it is a 7-item clinical assessment tool for children aged 4 to 19 years. The child is examined, and then the tool consists of 2 items for spasticity, 2 for rigidity, and 3 for dystonia. As you can see by the different colors here. The items are all scored as either present or absent, indicating the presence or absence of that hypertonia subtype. And mixed hypertonia is indicated if 2 or more items from the 3 subtypes are scored as present. It has got good reliability and good validity for the identification of spasticity. And and the absence of rigidity and moderate reliability and validity for dystonia. And you don't need a videotaping of the child in order to score this. And the manuals and the score sheets are all freely downloadable from the Holland Blueview site. The problem is when it comes to chorioathetosis, there isn't really a tool, except that the Monobalio team had come up with this dyskinesia impairment scale, which is the only tool currently in use where it addresses dystonia and chorioathetosis as well. The in cerebral palsy, all the other tools assess dystonia in general. So again, all these different tools are difficult to use in the clinical setting, and most of them will take time and involves videoing the child. And this would be in our clinical setting. It is usually in children who are then sent for deep brain stimulation and for monitoring the outcomes. But dyskinesia impairment scale is a useful one where it assesses chorioathetosis as well. And the Australian Academy of CP and Developmental Medicine has also come with a dyskinesia toolkit for clinicians, which is a very helpful one, which it would be useful if everybody could have a look at it. And there is the American Academy guidelines as well for pathways in CP, which is again another useful thing. So the summary is that the movement disorders in cerebral palsy mainly includes the dyskinetic CP, which involves the choreo and the athetosis. And of course, we didn't mention about ataxic CP, but again, this is a very, very small group of children, particularly with involvement of the cerebellum. But what's also important is there is no such thing as isolated spasticity or isolated dyskinetic CP. Often it is a mixed picture, and it is very important to try and differentiate between the spasticity and the dystonia or the dyskinesia. And there is very little evidence on various interventions, but the reason for that is the concept of looking at the functional outcomes have only happened in the last few years, and from now on, all studies that will be coming out would be looking at these meaningful outcomes, and perhaps the evidence will change. But for the practicing clinician, it's very important to keep in mind the activity and participation when it comes to managing children, not just with dyskinetic CP, but any child with disability. And when you prescribe the anticholinergics or prescribe benzodiazepines or prescribe baclofen, we really need to keep in mind the child as a whole, all the comorbidities and the functional outcomes. It's very important. There is no gold standard for treatment of dyskinetic CP. It is down to the clinician's experience and what the clinicians is familiar with. The HAT tool is a very important tool which can be used in the clinic setting. We have to try and look at ways on how we can quantify assessment tools, quantify the dystonia. And that is where artificial intelligence and other things come into play, which would be a topic for another discussion. I know Professor Gulati is very keen on it, and we've been working on it, where these children with dyskinetic CP, when they come to clinic, they are in a completely unfamiliar environment, and sometimes it's very difficult to judge whether our interventions have worked well or not. But on the other hand, if you can rely on carers' home videos, for example, and if you could have some sort of a quantitative assessment of the movement disorder, then perhaps we would be able to better manage these children. But that would be the future. And it's very important, again, for the goals that you have set should be realistic and attainable to result in better satisfaction. Thank you.
Yeah, thank you, sir, for detailed sum up of the cerebral palsies, as we have gone through the definition, then well demonstration of the classification by videos, and then like assessment tools and treatment. Now, there are two questions, but I think it is related with disability. So, as it is an international speaker, I think we'll talk later. So, moving towards now, I'll just to Rajesh Udani, sir, any sir comment on this?
Thank you, Biju. Excellent. I think you've given your clinical experience and along with that, a review of the relevant literature. And I think, the couple of things, observations in India, which are a little maybe different, I'm not sure because data is hard to come by. But at least in hospital-based studies, dystonia appears to be a prominent symptom in most of the cerebral palsies, which we see. And, etiology is also a little different. We see even now in this day and age, a lot of connectors and problems of those sorts. About a few things about treatment and a couple of questions to you. One is that how early do we start medications for, dystonia? Usually, as you highlighted, comes up in the later part of the first year. But, if you see the early signs of dystonia, do you try to treat or you just try because we've had this problem that we obviously just used to do therapy and find that the dystonia, if you see the early signs of dystonia in a case which has basal ganglia injury, HIE, connectors, etc., if you treat it early, they seem to not develop dystonic patterns. I'm talking of treatment with medications. And generally, we use gabapentin because that's one of the safer medications in young infants. Second question is on DBS. I mean, we've had a few cases we've done DBS on, and our results are, the dystonia decreases, pain, etc., and diminishes, but we don't have very good results as far as function is concerned. I know some of the papers you've quoted show improvement in function, and in India, the problem is when you spend so much, you want some improvement in function. So could you just comment on how early you treat and about DBS in general?
The early assessment of babies with possible dystonia is very interesting, and the general movement assessment, they say that they can identify it quite early on, and if we feel that there is a dystonic element to it, we often start gabapentin quite early on, very early on, because the babies, they tolerate it very well, and they don't often tend to have gut issues. But anticholinergics, certainly we don't use, although I know that they would tolerate it okay, but we tend to use more gabapentin than thing. And we do use it in babies. The problem with dystonia and DBS and for secondary dystonia, I know we've had this. In fact, I think we have got shared patients who have now relocated to UK, and I've had this discussion with JP and Terence. I think it's because people don't commit for DBS quite early on, and by the time they are sent for DBS, they're often 6, 7, 8, and if you leave until then, the secondary musculoskeletal deformities have set in. And the other thing is the workup of the patient. At King's, for example, they now routinely do neurophysiology as part of the workup to look at the integrity of the corticospinal tracts, like using central motor conduction time, etc. And if the corticospinal tract integrity is not there, then you could fairly assume that your neuromodulation is not going to make much difference. But I think these are all important points, but I think the overall important point is what are you trying to achieve? Because DBS may tackle the dystonia or the dyskinesia, as we know very well that it works fantastic in genetic dystonias. But I think the goal setting is important. Sometimes when, like for example, if the spasticity and the dystonia are coexisting, and often we find that you then put them on baclofen for the spasticity, and the dystonia get worse because the child has been using the stiffness to try and overcome the dyskinesia. So and yes, you make them very relaxed, but the function is gone. So it is, you have to really try and try different combinations and see. But because if the function doesn't improve, I know the children, most of the children I know who had secondary dystonia and have DBS, they are still on bucket loads of gabapentin, clonidine, clofen, trihexyphenidyl. It doesn't really make a difference. And then you have to and also it takes a long time as well. You know, it takes 1 year, 2 years to try and get the right settings. And it's I think finding them early and appropriate intervention might make a difference. It would be very interesting to hear from any adult colleagues because these dyskinetic children, they tend to get better. The dyskinesia tend to get better as they age, while the chorioathetoid movements tend to get worse. But that might be down to the basal ganglia circuitry. So it would be very interesting to hear from adult colleagues on that and how they manage the chorioathetosis. But again, when you ask, if you try to look at the quality of life, children who have chorioathetosis are not really bothered about the fact that they are chorioathetotic. it's the contorted, the dystonic postures are painful to them. The fact that they are moving all over, it doesn't matter. It is the positions where they get stuck at the doorways when the wheelchair is being pushed through, stuck at the back of the wheelchair. Those are that's the problem, and that sometimes will work fantastically. Like if we do targeted Botox, for example, it's sort of like managing that little problem. But that managing that little problem will do a huge good to their quality of life. That's all that matters. Yeah.
Thanks.
Yeah, thank you, ma'am. Pratibha,
Thanks,
ma'am,
Viju.
yes. Yeah,
Can
ma'am.
I make
Yeah.
a comment? So thank you very much for trying to simplify a very complicated topic, because this is like evolving still, the mechanisms, the various types of dystonias, etc. So this is, in fact, as everybody knows, one of the most difficult things to manage amongst the spectrum of CPs, the dystonia with or without a combination of spasticity, chorioathetoid, etc. And I was just wondering about the comment made by Rajesh, because that is true that, you know, the causes of dystonia in our country, India, are very different. And we still see a lot of connectress and severe birth asphyxia leading to dystonia. And therefore, the point under discussion about DBS would naturally be influenced by this. And as you know, many of JP Lynn's studies showed that the response to primary dystonia is fantastic. Whereas, you know, the moment you get to secondary dystonia, it varies with the etiology, the age, the, you know, where you put the stimulus in the DB for the DBS, etc. So that's why we are not very optimistic about giving, you know, a good prognosis after DBS. And as you know, that the cost here is phenomenal for an average family in India. And therefore, you know, of course, I'm sure that with advancing techniques, maybe we will have much better, you know, localization, and with the, you know, the stereo things, you can possibly localize exactly where you want to give. But many of those factors come into play when DBS is considered for a child with cerebral palsy. And nowadays they are giving a lot of emphasis on where exactly are you doing the stimulation. So that's, an extremely important point as well. So again, this part is evolving. And treatment wise, as you said, it's like so difficult because it just goes on and it takes a long time. And whether it be gabapentin or pacitane, I mean, tetrabenazine also some people use. Personally, I try to refrain from using it as far as possible unless indicated. And sometimes for these bad dystonic spasms, these benzodiazepines can also help during severe kind of dystonic spasms when the child is actually crying in pain. So that, this dystonic storm for that matter, that would also be one of the options, isn't it?
Thank you, ma'am. Any
Prashant, before
just-
we give it to before we give to Dr. Jackie for giving his old adult neurology perspective, just wanted to just mention one thing, that because DBS is pretty expensive, we have had a experience of bilateral peridotomy, and it was published last year in Neurosurgery Focus, and they do improve, their functional skills still improve, and the quality of life really improved. Yes, obviously, because overall the other situation has to be kept in mind, and those who had status dystonicus never had that after that. But we, two of our patients had permanent bulbar complications post palliatectomy. So I mean, so those things have to be weighed in, but they did help in the resource limited setting. They did improve the quality of life in that situation. Just wanted to add before handing over to Dr. Jackie. Yeah, thank you, Dr. Jackie, for
Thank you,
joining.
ma'am.
Yeah.
Thank you, ma'am. First of all, excellent presentation, Dr. Hamid. It was so nice to hear and listen. So elaborately, you dissected all the phenotypes of cerebral palsy. As an adult movement disorder specialist, mainly we see those kind of teenagers mostly. And we get a lot of referral with the delayed dystonia variant. And you mentioned it. I think the cause of this, it's really unknown, and we may study more on this issue. But to be honest, few patients what we are getting and being referred to as a delayed dystonia variant of cerebral palsy, they actually, somebody has missed the diagnosis. They actually have something underlying genetic cause. Recently, we faced 2 patients like this, and one of them actually had BPAN or SENDA. So that patient presented, as we all know, with this kind of cerebral palsy, kind of some features, some autistic behavior in the childhood, and then was doing more or less static and diagnosed as cerebral palsy. It was going on, and recently presented to us with ataxia with dystonia. And in MRI, we got iron deposition, and that was a clue. Before we saw it, okay, she was doing all through her life as diagnosed being cerebral palsy. And similar case, we faced one GM1 gangliosidosis, again referred to as a cerebral palsy, had some recent fever, some recent infection, deteriorated. As we all know, this kind of metabolic disorder get deterioration, and presented to us. So many of these dyskinetic, like delayed dystonia variant of cerebral palsy, may have something underlying genetic cause, those may be missed. And other thing I would like to mention about that, why that dystonia you pointed out nicely, maybe that abnormal sensory motor integration, that's the major player here for that delayed dystonia. Those are true cerebral palsy and true dystonia, but they are having delayed deterioration. If we see, as you were mentioning nicely, the pathophysiology of spasticity along with rigidity, dystonia, paratonia. We have recently wrote a paper also on the tone pathophysiology, and that's amazing to see. And if we go through it, only dystonia is the phenomenology where mainly sensory motor integration network circuitry is playing the role. So maybe with that age, is it some second hit kind of thing happening? We don't know. But yeah, we have to study it more. Coming to ma'am's question, as Professor Singhi was also mentioning that, yeah, we have done some secondary dystonia, DBS. We have done two PCAN cases actually, and one Plateau G6 patient. They presented to us with marked Plateau G6 dyskinesia, and we went for DBS along with Parkinsonism was there. So both STN and GPI you can do. We went for her with STN DBS. And she was doing good from the dyskinesia perspective, but ataxia remained. And we explained that, okay, we are doing it just to give a better quality of life, but that's not the full solution. And same thing for PCAN, the patient came to us with very young child with dystonic storm and nothing was helpful. So we had to go for urgent bilateral GPI DBS. So that helped the child. But yeah, with high pulse width, we are gradually titrating. We are seeing in the DBS clinic. But as sir was also mentioning, a prognosis we have to discuss with the patient's relatives, patient's parents, that okay, this is just to give some symptomatic relief, and that may be good right now at this moment. But in the long run, maybe the whole thing will not change.
Yeah, thank you, sir. There are a few questions in a chat box. Apart from drugs for hypertonia, what other conditions or factors should be taken care of to minimize the dystonia?
Sorry, what was the question again?
Apart from the drug for the hypertonia, what other conditions or factors should be taken care of to minimize the dystonia?
Oh, that's a good question. Of course, I think the focus really should be on all the comorbidities, particularly the gut-brain connection. I think it's very important. Sometimes simply addressing the constipation can do wonders to the dystonia, and also in children who are visually impaired, which most of these children would be, to address their visual impairment, and also to increase their communication skills. So all the addressing the comorbidities, and also to try and always be aware of the adverse effects of the medications that you are using is very important. And non-pharmacological interventions like lycra suit and those sort of things will also help. And I think Sangeeta had asked about sleep, and it's a huge thing. Now it's huge because it's very complicated, Sangeeta, because Dr. Segawa, after discovering the Segawa disease, subsequently all his work, as Dr. Pratibha would know, has been on sleep and locomotion, sleep and dopamine, because that's the whole thing. I think the issue with sleep and movement disorders is massive. You can have a whole symposium on it. And the dopamine, the sleep regulatory structures within the basal ganglia, it's very keen. But from a practical point of view, I think the problem with sleep is, again, those issues like gut, etc. But also, it's often the medications that we use. I personally have been to blamed myself for sometimes using too much anticholinergics. The anticholinergics will mess your sleep up, and you don't often realize that. And also in those children with visual impairment, where the anticholinergic, you have the anticholinergic side effects, and sometimes by just being aware of that alone can make wonders. And also you have to be aware of the sleep apnea issues as well with these children. So we often have a very low threshold for sending them for sleep studies. And also, and those children who go to King's for deep brain stimulation, they also have a very state-of-the-art sleep lab, and they often get seen in the sleep lab as well. So sleep is massive in terms of managing. In fact, I think it is more cost-effective rather than thinking about DBS and other things. It's more cost-effective to address these things, which will secondarily make a huge improvement to the dystonia, rather than being a bit trigger happy and going for the gabapentin and the trihexyphenidyl. I think it's not really, it's more cost effective to try non-pharmacological routes, I think.
That's true.
Yeah.
Can I ask a quick question? Jackie, have you done DBS on children with connectors or severe birth asphyxia with evident, basal ganglia involvement on MRI?
Not yet, ma'am. Not
No.
yet, ma'am. Not yet.
Because, I often wonder like what, and they can really have sometimes bad dystonias.
Yeah.
So,
True. Yeah, we've
Targeted
got lots of.
Botox.
Yeah.
sorry.
But sorry.
I was saying, ma'am, we have given Botox to them, like mainly targeted Botox. But
Right.
as you were mentioning, in generalized dystonia, how much Botox you can give. So in
Yeah.
those cases, GPI DBS will be helpful. Have not done it.
No.
We have lots of G6PDs coming who've had DBS, but they are still on massive loads of medications as well. So I don't know whether it really worked or not.
Mm.
I think for the primary genetic dystonias, fantastic. So,
Absolutely.
Fantastic.
Mm.
yeah,
No doubt.
and that too for a few specific ones like GNA01, etc.
Right.
And TAP, yeah, to be, but CMT2B, etc. But other than that, I think it's effective.
True.
So,
There
what's
was a
your
question on this graph. Why is that the rights of people with disabilities, RPWD Act? Why is dystonia not or dysgraphia not in the Act? I don't know. For rights of people with disability, I don't know whether dyskinesia, dystonia features in those. I don't know. I mean, it's a very important point if you think about it.
Yes, sir. One more important question, sir. What's your approach for a status dystonicus in children, and what's the use of Botox if the systematic drugs are not working in this condition?
Botox for status dystonicus? No.
Okay, and
No.
approach for the status dystonicus in children?
Approach for status dystonicus is, I mean, depending on the severity, the important thing is to try and address the triggers and to address make the child stable, giving specific focus on the hydration, etc. And in terms of medication, clonidine is often our go-to medication, IV clonidine. And if that doesn't work, then we have used clonazepam and diazepam as well. But maintaining hydration and holistic overall managing the child often works best in terms of status dystonicus. If it is dehydration or if it is an infection which has triggered it, then addressing them will also help. But the status dystonicus is often seen, particularly like the GNA01s, where massive doses of chloral and clonidine often helps. In secondary dystonias, status in CPs, status dystonicus is very, very rare. It's often in the primary dystonias where the status dystonicus is a problem.
I had a question, Biju, about clonidine use in dystonics. We've used it in very high doses, in fact, the status dystonicus, but in regular dystonic CPs, do you use it early? I mean,
Yeah. Well,
works
because
well.
the reason is, pointing to what Samhita said, the clonidine also helps with the sleep. And sometimes in those children where the melatonin is not working or they're just tolerant to melatonin, or it doesn't work for whatever reason, because melatonin, you can't really use melatonin as a sedating agent. Melatonin is best used as a chronobiotic to try and get the sleep cycle correct. But in these children, clonidine works very well for the sedation, and that also has a positive effect. And I don't think the hypotension to us is not. I haven't seen it as a major problem.
Not really.
In fact, the hypotension, bradycardia is a problem, but in a select small number of children. And if we see bradycardia, then we don't tend to use. Hypotension, we tend to ignore. In fact, we used to bring them in and do a test dose in hospital before starting, but that we have stopped for the last couple of years. We don't do it anymore. So we tend to use it quite early on because we don't. The other problem is we have to use chloral hydrate. The chloral hydrate, you develop drug tolerance to it, and then you have to use higher doses to get the same effect. That's the problem.
So early means how early, Biju?
Even in babies we use.
Infants
Yeah, infants we use.
for dystonia.
Yeah.
You're
1 to 2 mics
starting
per
as
kilo
early
per
as that.
dose for our for 6 hours,
Personally,
6 to
I
4 hour
tend
will work.
to kind of wait till the child is a little old,
Yeah.
in
It's very safe.
infancy.
It's a very
Yes.
safe. Yeah,
Mm.
and I think the sedative effect of clonidine is not related to its action on the alpha 2 adrenergic receptors. I think it's a different mechanism of action. So it's okay.
How many sessions of Botox can be tried maximally in a cerebral palsy? How many maximum sessions of Botox can be tried in a cerebral palsy?
I didn't catch that.
No, how many maximum sessions of Botox can be used in a cerebral palsy? It's a vague question,
Oh,
but not particular
I
indication.
mean, there are children who have been having Botox for. I mean, we've got one child who've been coming for like more than 10 years, 10, 14 years. We don't. The problem with Botox is we don't tend to repeat Botox. I know it varies. In other centers, there are Botox is used every 6 months at least. But at Great Ormond Street, we don't tend to repeat it not less than 12 months at least. And we often try to leave at least 18 months before 2 injections. The reason is the positive side effects of Botox, the literature out there is almost all of the existing literature is on short-term outcomes. There is no literature on long-term outcomes. And if you speak to orthopedic surgeons, they say like in theater when they open, when they do the incision, by just looking at the muscle, they know like whether this muscle has had several injections of Botox or not. So the long-term effects on muscle structure is a problem. There are a small number of children who have slightly more frequent Botox, but those are more when you are thinking about pain and palliation. But in terms of functional goals, we don't tend to repeat it very often. And also, so the normal Botox pathway is like you inject and then you bring them back after 6 weeks for an assessment and then bring them back after 13 weeks for another assessment. And if you feel it's not working, then you don't tend to repeat it. Because I don't think if it works, it works. If it doesn't work, then there's no point in repeatedly using it.
Any experience with the role of hydrotherapy in a dystonia?
Fantastic. Hydrotherapy works beautifully. If there is a facility that you can access hydrotherapy, it works fantastic for dystonia.
So it's like
The moment they're in the water, things like dystonia gets better.
So is there a particular kind of training required for the therapist hydrotherapy?
Yes, I think it depends. The temperature, etc. It's not the same thing as like taking the child to a swimming pool. So obviously the temperature, everything has to be maintained, and also there should be set up for children who are like tracheostomy ventilated to get into the water. I think the current protocol is there should be 2 therapists per child when the child is in the pool, and I don't think many facilities can have that sort of luxury. And also in terms of number of children who can be in the pool at one time is limited to 2 at the moment. So those logistics issues are a problem. But hydrotherapy and also hippotherapy on the hose, it's also fantastic for children with dyskinetic CP. They do very well on the hose actually.
Shefali ma'am, any comment from your side?
I think it was an amazing talk as usual, Biju. Really grateful to you. I think we'll request you for one final message, and I'll request final message from others also after you.
I think the take-home point is when it comes to neurology, which in essence is neurodisability, when it comes to pediatric neurology, I think we should always be we should always be goal oriented, and that goal setting has to be done with the child and parent in mind, and all the other treatments should be directed towards that goal. I think that should be I think that is what I have learned from neurodisability.
Biju, I feel, in our resource limited country, and we need to have understand that holistic evaluation and holistic multidisciplinary management is important, because sometimes CPs are just being followed by physiotherapists, they are not going to doctors. So it has to be holistically evaluated for all the comorbidities, and you have short-term and long-term goals. And, that is something very important. And that is what I always feel. Dr. Udani, final take-home message.
Well, I think my take-home message is a little different, in the sense that in a country like ours, when the patient has already developed the problem, it's extremely difficult with logistics, with expense, with the lack of government or other support, with long distances, etc. And of course, to access all these therapies, which are obviously so important in their management. And so I think there should be some, I think, awareness increased amongst the primary pediatricians who look after pediatricians, gynecologists, etc., to prevent many of these very preventable conditions. And I think that has been frankly neglected, that we still have few centers doing hypothermia for HIE. We, still have, a terrible condition like connectors still existing in so many, in such large numbers. All these things are very important. And, finally, prevention, like it's a very old saying, but it's extremely important in this context. Prevention is far better than cure. So I think that is something which unfortunately is not being addressed as much as we should be.
So absolutely, sir. You have primary, secondary, and tertiary prevention. What we are talking today is only the tertiary part, I think.
No,
and
I'm
some
not
part
saying
of the secondary.
this topic, of course, is very important.
No.
But I'm not saying a message kind of thing. Yeah.
No. What I mean is, everybody, all pediatricians and pediatric neurologists and obstetricians should keep in mind. What you're raising is a very important thing. I'm just saying what we are generally end up talking is mostly tertiary prevention and somewhat early diagnosis, what we are trying to pick up as a secondary prevention, but we are not talking about primary prevention, which should be talked about. So we should focus when you're seeing primary, secondary, and tertiary prevention. And we are having so many advances in the rehab part, also getting so much of technology and all, and also with the tele thing, so that you have and the video recording of the general movements and everything, and when the movement disorders, we should have so many platforms available, so that you don't have as from the periphery, they can be having access to the expert. We're trying to make some actually already we're doing, not for this point, but we're making for the genetic reports, because half the time they're VUS, we don't understand. So that platform we are developing along with IGIB, so we'll be soon launching that. So I think that is very, very important what you have flagged, sir. Dr. Jackie, please you, and then I'll ask Dr. Saha from Bangladesh, and ma'am will give the final, and then Mahesh will give something in the end with the vote of thanks. Yeah. Dr. Jackie.
Oh, thank you. Sarah's mentioned very nice, like prevention, as we were mentioning, and proper diagnosis. And many times, as I was mentioning, we are getting cases, lots of cases like this who are misdiagnosed, and that's a different topic. But cerebral palsy mimic condition, many times people
Dr. Jackie, we had a very wonderful session last week with 6 of CP mimics from Pan India. Yeah.
So we have to prevent those things, and detection is very important.
Yeah. Dr. Saha, Bangladesh.
Thank you, ma'am. Actually, that was a very wonderful session. Thanks to Dr. Biju Hamid for his excellent presentation. Probably in a third world country like India and Bangladesh, we should be very much give our attention to prevention of all these preventable causes of dyskinetic cerebral palsy, like as the Brajesh Udani and other told, the prevention of parental asphyxiation as well as the connectors, which are usually still we are encountered in our country also. But regarding the management of status dystonicas. Actually, it's a very difficult situation to manage in our countries like India and Bangladesh also. We don't have any injectable, that means pronidine. We used to give the either midazolam or something else for managing the acute dystonic storm in addition to addressing the infection and other cause. I think there should be the strategy in our country like Bangladesh also. Thank you, ma'am.
Thank you. Thank you, Dr. Saha, giving our resource constrained perspective of what we both countries share. Dr. Singhi. Ma'am, you're muted.
Okay, thank you, ma'am.
Thanks, Dr. Saha.
Okay.
Thanks. I think everybody's made very pertinent comments. We all see cases, and I have always been sort of advocating having a CP registry in India so that we can, at least learn from each other and see the, dimensions of the problem as they exist. Right now, we just, each one of us relates to their own experience. And there's very little in terms of common kind of understanding of cerebral palsy in our country. And certainly, I mean, prevention, that goes without saying, not missing the CP mimics also, and having goals for, therapy. All that is, of course, so important. But unfortunately, in our setup, very few centers have that sort of a population that comes to them regularly, where you can, set the goals, work with them. Very few. I'm not saying that they don't exist, but in general, if you look at the masses, that sort of a care is not available. And therefore, if we can have something wherein they can approach and get proper advice, that would be very helpful.
Thank you, ma'am. And I think with your statement, I think we at AIMS, along with Ghosh and along with Sangeeta, who's there with CMC Vellore, we have been working for quite some time. So I think we give us a target, Dr. Biju and Sangeeta, on 3rd December, we launch the registry, right? We have been sitting on it for long. We just finalized the final things and we launch it on 3rd. Now, ma'am has given us stimulus. So on 3rd, without taking permission, I just announced it. So we'll have to just get over with it and have the registry.
That's like basic to start something in the
Ma'am,
country.
we've already been working. It's just the
I
final.
know we've always been talking about it.
Yeah, we've now done it. We've not put it. Yeah, it's 3rd December.
We really
3rd
need
December.
to do it. Right.
The date aa gaya abhi, aaj ho gaya. We'll work behind the scenes and do it.
Could I also add, Dr. Shafali? I know we've been talking about, Dr. Saha has been talking about, low resource countries like India, Bangladesh. It's not different even in high resource countries as well. Particularly in the region where I am now, it's a country with huge resources, but with lots of malls and it's lots of nice restaurants. But you go to I'm yet to see a child in a wheelchair, and that's not because there are no cerebral palsy children. They are hidden.
They are not integrated.
These children are languishing in homes with maids, or so it doesn't matter whether the country has resources or the country don't have resources. When it comes to children with neurodisability, they are still underserved.
Absolutely.
Dr. Biju, before I hand over to Mahesh for his comments and his vote of thanks, I just wanted to add, adding on to what you said, there are two things, one has a medical condition and that becomes a disability because of your environment. Environment is both physical and people around you. I think if you don't have, like you have physical environment is okay, I think in the developed, and at least maybe there's more empathy and humanism. Here, the problem in India is one, that you can't even go anywhere on a stroller or a wheelchair. There is nothing. I mean, most of the places are not accessible. Number two is the attitude of the people. It is so horrendous and so demeaning. And I think the word humanism nobody understands. And so I think these are things. There has to be a change, and neurodiversity has to be there, and respect and all of them, all of the people with neuro disability and any kind of disability or any special needs or any neurodiversity, whatever we may call, have the equal fundamental right to life. And I think they are not being, anybody is not being given as a favor. It is their right, and there should be equity of things. Somebody who needs, can't talk about equality of resources, equity of resources. And I think the mindset is very important to understand, which is a big issue.
Oh, true.
Mahesh,
Yes, ma'am.
sorry, you're going to speak late, but you can
Yes,
wind
ma'am.
up with your first message before you give a vote of
Yes, ma'am.
thanks. You better give a message.
Yes, ma'am.
It's
What I feel like,
different
ma'am,
than what has
Yeah.
been said.
we had used this HIT score, ma'am, to assess more than 100 patients, ma'am. And in our study, we found that almost 50% of it was dyskinetic and a mixture of dyskinetic and spastic. Though the literature says that spastic is most common, what we found was almost 50% had some amount of dyskinesia or predominantly dyskinetic CP, ma'am. And I feel like dyskinetic CP patient had to be managed differently when by the physiotherapist. Because physiotherapist, most of it is based on spastic CP. They tend to give this AFO and that can be counterproductive to dystonia. The child is dystonia.
Absolutely.
Moment you give AFO, child become more stiff, ma'am. And sometimes we put such a tight strap, child will have skin ulcers and wounds and all, ma'am. So even the physiotherapist has to be told that they have to manage this dystonia CP differently. Both medication wise and physiotherapy also has to be different. Otherwise, it's a very wonderful review of movement disorder in CP. Thank you, Biju sir. I'd like to thank both our experts, Dr. Udani sir and Jackie, for their wonderful inputs, and Dr. Prashant for nicely moderating this session. Again,
Prashant, any message? 1 second, he's there in the
Okay.
periphery and doing outreach. Prashant, any message from the outreach specific?
Yeah, ma'am. As I said, I'm trying in a periphery to like it's a teamwork where there was the two parallel track therapists will say don't use the medication because sometimes with the use of baclofen child may be down or a sleeping, excessive sleeping. So I try to make the complete teamwork where, as you know, Umang Autism Center and Cerebral Palsy Center at Latur, I'm trying to coordinate all this and now working on a hydrotherapy there. That's where now we need to get trained our therapists from a good center. So definitely looking for a good association where rural part of the people with the cerebral palsy will get attached with the center.
And we have to focus on transitional and palliative care as the case may
Yes.
be when they are becoming older or somebody is becoming pre-terminal or something. Both the things
Yeah.
are very much neglected. Mahesh.
Yes, ma'am. We'll be having another session by CPSIG next Wednesday also. I'll be posting the details on the WhatsApp group and emailing all the members. I expect a response next week also.
Shifali ma'am, you are mute. We are unable to hear. You are mute, ma'am.
Yeah, I'm saying that you can register from the same link for all sessions till April because all the SIGs are fixed till April, and all the YouTube channel link will be shared with everyone shortly, where all the webinars from this year, beginning of this year, are there. Thank you so much for joining. Thanks a lot.
Thank you.
Thank you.
Thank you. Thank you,
Thanks.
everyone.
Good night.
Thanks.
Thank
Uh,
you.
Thank you. Thank you very much. Dr. Biju, can you? Stop. Dr. Biju is left, right? Okay. Thanks. Mahesh,
Yes, ma'am.
मेल कर देना बेटा वो वाला जो
हाँ,
वो जो प्रोजेक्ट्स और
Yes,
है ना,
ma'am.
ठीक है?
हाँ,
Okay, thanks. Thank you. Thank you,
Yeah.
Mansi. Thank you.
Good
The
night.
project नहीं, the research grant जो देना
Yes,
है और जो
हाँ,
mentor mentee वाला है ना,
Yes,
ठीक है?
हाँ.
Thank you बेटा.
Yes.
Thank you. Thank you,
Most
Mansi.
welcome, ma'am. Good night.
Thank you.
Most welcome,
Thank
ma'am.
you. Bye.
Yeah,
Bye.
good night.
Bye. Thank you, sir. Thank you, Mona.